It's my pleasure to welcome Professor Catherine Arnott Smith to talk with us today. Kat is a professor in the Information School, and her research focuses on consumer health informatics and the history of medicine. Previously, her work has touched on online health information, attitudes toward COVID-19 vaccine, and how patients interact with their health data. So as you can see, a lot of shared interest with people in our department and people pursuing the minor in science communication. So please join me in welcoming Professor Arnott Smith.
Thank you. Yeah, so I understand it's a mixed audience in terms of discipline, where you're coming from. So I'm going to pause every so often to make sure we all are on the same page in terms of what I'm talking about. But in a way, my job is easy because you are all consumers and/or patients in this room. Some of you statistically have been caregivers of people who are patients, even if you haven't been yourself. And so I'm talking about a technology that is going to hit everybody in the room if it hasn't already, no matter what your major is. So the movement known as Open Notes is what I am mostly talking about today. And it began as a collaboration between 3 medical centers, one in Boston, one in rural Pennsylvania, and one in Seattle. And the notes in the Open Notes movement, because that's what it is, it's a movement, are textual summaries of doctor visits. And in this first published report of research on Open Notes, 20,000 patients were given the opportunity to read the notes that were generated by their caregivers, documenting their clinical office visits. And a very high proportion of those patients, as high as 87% in one of the 3 centers, agreed when asked to say, do you agree or disagree with the statement, I felt more in control of my care because I had access to notes. A small minority, depending on which of the 3 sites you were looking at, said, it was 8%, said the notes caused confusion, worry, or offense. So the Open Notes movement webpage, which is given in red on this slide, features a long list of citations to relevant research published since the movement started, a heck of a lot of it coming out of the original site that launched the movement, including this very important first study, which cited more positives than negatives out of the encounter with the notes. And that first study, which is on the handout I had distributed ahead of time, was by Del Banco et al. So pausing a second, anybody want to raise their hand if they're not sure what a patient portal is? That is a term of art. It is a term of industry. We're super close to that big electronic medical records company called Epic, which you've probably heard of. And my chart is, which a heck of a lot of you probably have because it's Wisconsin, is a outpatient kind of patient portal. So when I say patient portal in this talk, I'm talking about the thing that consumers and patients have access to look at their own aspects of their own healthcare encounters. So we flash forward, whoops, not that far, from 2012 to April 2021, when Open Notes became the law of the land through the Cures Act. And this federal rule, among other things, gives patients access to all the health information in their electronic medical records without delay and without charge. Now, people already had access because HIPAA, and depending on what state in the US you were in before HIPAA, you had access already. So many people did not realize that they had access, but they in fact did. The big twist of the Cures Act, which is enabled because of the technology called patient portals, is the without delay and without charge part. So simply having that really fast access, often in next to real time, that is the new twist. Access was for the most part already there, but access in the moment is the new thing. Healthcare systems are going to vary just on how fast patients do get that access. And the point to understand at the moment is that they are getting that access through their portal. And that means that if you have had an encounter, or if you are a friend, family member / caregiver of somebody who has a portal, and you've had an encounter with the US healthcare system, you have access now to text that looks like this. And I want to stress, because in my line of work you have to stress this, this is not text from anybody's actual record. I would be in so much trouble if I showed you text from anybody's record except my own. I am free to give that out on street corners if I want to. I probably won't. This is sample text, which is now available, unfortunately, only through the Wayback Machine. It was up on a federal health IT agency website for a long time, and it's still available only through the Wayback Machine. But it came from a toolkit to help people understand medical records, which was produced by AHRQ, which is the Agency for Healthcare Research and Quality, part of NIH. So OpenNote's usage has been measured in different ways, which you can read about at the OpenNote site. But to illustrate recent trends in usage, what I like to do is look at the Health Information National Trends Survey. The acronym for that is HINTS. And it's a long-running survey project out of the National Cancer Institute. And they started asking questions about people accessing medical records online in 2017. So it's important to understand HINTS is an initiative of the National Cancer Institute, but these surveys are surveys of the general adult population, that you don't have to have had an experience with cancer to participate in these surveys. And the surveys have happened in different means that are all explained on the HINTS website. In 2022, that was the first year they used both web and paper forms to kind of expand their reach. So OpenNotes, remember, was just launched, although not mandated federally yet, in 2012. Just since 2017, HINTS has asked respondents, have you ever been offered access online to your medical records by your healthcare provider? And 11.8% reported they had accessed 10 or more times. Now, in my experience, professional and personal, with online support groups, I look at that and I'm like, that's not very much. But actually, for the general adult population, those are the high users, according to this survey. And in 2022, there were 6,252 respondents. That counts both web and paper. And 70.3% reported they had been offered such access in the first place. So it's definitely out there as a thing that people know they can do, according to this most recent data. So the availability of clinical notes through this thing called a patient portal, that is a historically more recent phenomenon. But the question of how patients relate to what they see in their records is a much, much older research domain. And the roots of what we now are calling open notes are actually in the consumer movements of the 1970s. In the 1970s, access to your own medical record was actually unusual. And in 1974, there was important federal legislation passed, the Privacy Act, which, because it was a federal law, generated naturally a commission tasked with investigating challenges to data privacy in different contexts. So privacy is not just a 21st century thing, right? As long as there has been concern about privacy being violated, we've got people being worried about privacy. And one of the contexts that this task force looked at was medical contexts. And the commission prepared a report, which is available online, issued in 1977, in which they commented, although the content of a medical record is becoming harder to control, at the same time that the number and kinds of decisions in which it figures are growing, it is still rare, they wrote in 1977, for an individual to be allowed to see, much less copy, a medical record pertaining to himself, sick, or to check the accuracy, timeliness, or completeness of the information it contains. So you can see the need for advocacy around patient access right there in 1977. And in fact, the ability of the patient to improve the quality of the record by making it more complete, by making it more accurate, that was one important reason that advocates for a long time have been behind different movements to let patients see their own notes. And one important argument, in this space was that access to your record was educational, that medical records could be part of ongoing self-education on the part of the patient, which the idea was would enable smarter consumer health behavior. That if you are a consumer of health services and you understand why you are a consumer of health services, that is going to make you a smarter consumer. That was the idea. But critics of the original access movement argued that the original language in which medical records are written is professional language, it's technical language. Patients wouldn't be able to understand what they were reading, and that automatically reduced their educational value. I don't speak Spanish. If you give me a document in Spanish, it has not improved my understanding of what the document is about at all. I have got to go learn Spanish or jump on Google Translate, right? A related anxiety expressed by these critics in the 70s and 80s was this fear that the lack of understanding would result in patients worrying, having their anxiety increased based on what they read. Was it actually harmful, in fact? This was a position that people took and have taken ever since. Was it actually harmful to give patients access? So from the very beginning of the argument over access, long before we had such a thing as electronic medical records in a widespread way, or patient portals which rely on electronic medical records to work, both medical terminology and patient comprehension of medical terminology were recognized as potential challenges to meaningful access. Not just access, turn people loose on their stuff, but access that actually affected change and made people better in some way. So medical record terminology, technology has changed a great deal since the dawn of the patient access movement, but all those concerns are still very much with us in 2024, as was revealed in the healthcare professional literature after Open Notes was first published in 2012. I did a deep scan of the medical literature in PubMed, which is the international best source of medical literature that is free to everybody, not just here, but all over the world, because of our federal government. I did a deep scan of the literature there, and I identified 192 published articles published since the initial work by Del Banco et al. In 2012 about those 3 medical centers and the 10,000 patients. And these were all articles that explicitly referenced Open Notes as a movement. So I was looking for researchers who published research that they had done based on Open Notes. It was extremely specific. So of those 192 articles, 32% were what I'm calling on the slide patient-centric. They were studies in which patients were active participants. 21% focused on physicians. 7% focused on aspects of clinical text itself, but not on humans, either patients or physicians, either generating text or interpreting it. They were just about aspects of the machine. And if you're wondering, yes, there was overlap between these 3 sets. So some articles were talking, those are the interesting ones, studies of patients and those patients' physicians talking about everybody's reaction to seeing notes. But that was not more than 8% of the total. These were actually 3 silos. It's interesting to me that actually the largest proportion of the articles, 40%, were what I'm calling other-centric on the slide, because articles in this category weren't research investigations. They were commentaries, they were op-eds, They were reports of, here's my patient experience looking at my record, an N of 1. System design pieces, how do we have to design our systems to accommodate open notes? How do we implement open notes? That sort of technical question, or very personal, subjective expressions of opinion about open notes. So I think the sheer busyness of literature in that category is reflecting both the run-up to the federal mandate and the reaction when the federal mandate actually happened. Because open notes, as you might imagine, has generated a lot of professional conversation in healthcare. And the findings I'm going to talk about on the next few slides are excluding all of those other-centric ones, because that's a whole different kind of talk. I was trying to get a handle on what research had been done investigating the terminology challenge of open notes. Because I have a background in the history of medicine, I knew it was not a problem induced by technology. I knew that it was a problem that had been recognized and worried about before technology. So I wanted to see what was going on with that terminology challenge from a health literacy point of view. And the answer turned out to be not much. So there were 61 patient-centric studies published between 2012 and September of 2023. And of those 61 patient-centric studies, 46 of them asked patients about their experiences reading their own actual notes. Of those, in just 18 studies, patients were asked about either their readability, the notes' readability, or their understanding of the notes. Of those 18, just 4 of them used validated health literacy instruments that were direct measures. And those 4 are on this slide. I should note that some studies were using multiple instruments, as always happens, so these add up to more than 4 of 18. But what's going on in these 18 is patients are assessed for something getting at understanding of what they read in the notes. So these are pretty standard health literacy instruments, everything from a 2-item screener all the way through short tests of functional health literacy in adults. These are all over the literature, and I'm happy to point you to resources that will help explain these, but they're all pretty standard. Now, 5 of the patient-centric studies used indirect measures. In 2 cases, it was the brief screening questions, which were developed by the researchers Chu, Bradley, and Boyko. Again, widely used. I've given you a citation on the handout. What that instrument does is it's used to identify patients who have low health literacy based on self-report. It's an indirect measure because responses to the questions have been found to map to direct measures of health literacy. So, using one of the instruments on the previous slide. So these indirect measures use questions like this. How often do you have to have someone help you read hospital or medical materials? And how confident are you filling out medical forms by yourself? So the idea is that instead of making the patient sit through filling in a bubble sheet, which would be a direct measure, in this case, you're just saying, hey, patient, do you have to have somebody help you fill out stuff? And they say yes or no. And the brief screening questions got used in combination with some of the instruments on the previous slide. So, how do we actually know what patients understand about what they're reading? This is what's left of the 18 patient-centric studies, and this is understanding as measured by self-report. So the Open Notes research team based in Boston has from the beginning relied on the note reader's self-report of confusion, and they've always used that word, confusion. In the original 2012 study, from 1 to 8% of patients at those 3 large medical centers said the notes caused confusion, worry, or offense. And what this means is the participants were asked, did the note cause confusion, worry, or offense? And 1 to 8% of them said yes, it did. Of those 18 studies in which readability or understanding got assessed, 44% of them relied on this original confusion question, that same question, confusion, worry, or offense. And I've put some examples of the items used to measure confusion on this slide. So this was between 0 and almost 15% of participants reported confusion, or an average of just under 6% across all the studies. So these are the sorts of questions that get at confusion and understanding. So back to hints from the National Cancer Institute's hints survey. They found higher numbers for a related question: how easy or difficult was it to understand the health information in your online medical record? Notice a really high proportion saying it was very easy or somewhat easy, but just under 11% said it was very or somewhat difficult. And my concern, obviously, is that 10.8%. That's what I worry about. Because people who find it difficult to understand medical content are going just where you're probably all thinking they're going. They're going online. They're going to Google. They actually talk about this in some of the studies. They go to Google. They go to WebMD, which I've got different opinions, and we can talk about that maybe in the Q&A, how well that works. There's like a huge, it depends here, but that's what they're doing. Nobody's teaching them anything. They're just jumping online and Googling. So one real post-Cures Act response illustrates, I think, the current situation for patients, both as an incredible challenge, but also an incredibly good opportunity. It's good and bad, right? A cancer patient named Ann Dabbs is very active in her diagnosis community, and she published a piece online in a widely circulated newsletter, which was distributed in different means, but it's also a web page, in a context of a rare cancer. So this is a diagnostic situation in which it's very difficult to find people who know what you have. It's very difficult to find physicians who can correctly diagnose you, and so it's usually diagnosed at stage 4 for that reason. So the whole access to information thing is incredibly sensitive in a community like that. The name of her piece is Preventing Patient Portal Panic. And she starts by acknowledging the effect of the Cures Act and the open notes philosophy. She then goes on to list 5 Ps to maximize potential of portals. And point number 3 relates to health literacy. It's proper terminology. Notice the word proper. So Dabbs acknowledges, and the punctuation is hers, medical terminology is hard to decipher until you are disciplined enough to educate yourself about your disease and its unique language. But she stresses access can not only improve patient safety, but boost patient activism. She is saying this as a patient with a lived experience of being an activist and doing outreach around her rare cancer. And she calls it a wonderful tool to help us each become our own best advocate. Some more tips she gives. Make a cheat sheet. Become familiar with stock phrases. Medical record text is full of stock phrases that are unfortunately very easy to copy and paste and to insert without thinking, but medicine is like that. It's always like that. She says, learn which words prompt your anxiety, your fear, or your misunderstanding, but are actually just medical jargon, which means they're learnable. Everybody's got jargon. Every field in the universe has jargon. You can learn it. Learn to look up common medical abbreviations, she says, and she lists 3 helpful resources: Google, WebMD, and NIH. I'm not sure what NIH actually means, but so I could add, again, more to this list of resources, but that's a whole nother talk. Let me repeat, when it comes to understanding patient understanding of notes and the role of terminology in patient self-education through the medium of open notes, we don't know. We don't know a whole lot in this space. We don't know much about patients' health literacy skills either, including their ability to navigate medical websites and distinguish good from bad information, because we generally don't investigate those skills at all when we study open notes. So what there has been is a reliance on patient self-report of understanding and or confusion. There's also been a dominant assumption that people who read the notes understand them. I think that built-in assumption is not terribly scientific. Many researchers in the literature I found never even ask if the notes have been understood. We're just assuming that we open the gates to the text and we're done. So I want to close with a study I found quite interesting, in part because it comes out of the same medical centers that Open Notes did. And I have to imagine these folks bumping into the researchers at Open Notes in the cafeteria. It was a tantalizing study by Yanomsky et al., which was a 2020 survey of 225 dermatology patients. And these participants generally rated themselves as confident in their technology and health literacy, and they didn't think that looking at their health information online would be confusing. Of the 225 respondents, understand that most of them were highly educated people. 70% of them used their portal at least monthly. So the researchers asked the participants to choose their own diagnosis off a short list, and just 12% were able to do this. 35.1% chose the wrong diagnosis. 47.1% didn't identify a diagnosis at all. And we don't know what that means, right? Were they like in a hurry? They're like, I don't understand the question. We don't know what that means, but that's a big chunk of them. The authors write that despite these errors, 61% of them felt their report was somewhat easy or very easy to understand. So I saw that and I'm like, oh, for heaven's sake, that's ridiculous. So what Ann Dabbs is talking about in her cancer patient newsletter, she's modeling something for patient readers of Open Notes. She's acknowledging that some words might cause anxiety with some people, but it's still possible for patients and consumers to inform themselves to relieve that anxiety that they notice in themselves and become comfortable with the words, because like anybody else who has to learn a new language, becoming comfortable is, what you have to do to learn. But I remain concerned that this is a bigger problem than words. So I'm a total advocate for patient access, but I also argue that as researchers, we need to be asking the right questions. And now it's time for questions from you all. Thanks. Should I turn this off?